Pediatric resuscitation causes of cardiopulmonary arrest in children. Respiratory causes are more common than cardiac causes, respiratory failure, and terminal stages of shock. Cardiopulmonary resuscitation CPR initial assessment pulse and breathing absent. Start for CPR compression plus ventilation. Reassess after every 2 cycles. Attach external automated defibrillator. Look for and treat reversible causes. Pulse present and breathing absent. Provide ventilation, positive pressure ventilation. Rate 20-30 breaths per minute. Assess every 2 minutes. If pulse absent, heart rate less than 60 beats per minute with poor perfusion. Start CPR. How to give? Rate 2 rescuers, 15:2 ratio, 1 rescuer, 30:2 ratio outside hospital. If endotracheal intubation with 2 people, compression 100 to 120 per minute, breathing 20-30 per minute. If shockable rhythm, deliver shock 2 joules per kg, continue CPR and reassess. Repeat shock up to 10 joules per kg, no response, refractory. Drugs like lidocaine and amiodarone. If non-shockable rhythm, immediate push of epinephrine 0.1 ml per kg of 1 is to 10,000. Repeat every 3 to 5 minutes. Continue CPR for 2 minutes and reassess. Initial assessment. Verify scene safety. Position supine on a flat hard surface. Immobilize patient if fracture is suspected. Road traffic accident. Check for responsiveness. Look for any body movements. If unresponsive, shout for help and activate an emergency response system if it in public. Check for breathing, chest movements and pulse. Brachial artery, infant and carotid or femoral artery more than 1 year. Simultaneously check for less than 10 seconds. Circulation chest compression to be performed. Site lower 1/3 of sternum 100 to 120 per minute. Depth 1/3 of AP. Diameter of chest. Always allow full recoil to ensure filling of heart. Push hard, push fast. Airway head tilt, chin lift, jaw thrust. Breathing non-invasive bag and mask ventilation. Invasive endotracheal intubation preferred in hospital. CPR, prolonged CPR. Endotracheal intubation. Type of tubes cuffed. Type of size of ET tube. Age in years plus 4 divide by 4. Age in years divide by 4 plus 4. Invasive endotracheal intubation preferred in hospital. CPR and prolonged CPR. Cuff pressure less than 20-25 cm for water to prevent pressure necrosis. Depth of insertion is 3 into age in years. Cricoid pressure routine used to avoid to prevent cartilage damage. Rate of breathing 20-30 breaths per minute, 1 breath every 2 to 3 seconds. Rate of breathing 20-30 breaths per minute, 1 breath every 2 to 3 seconds. Vascular access. Goal: administration of medication. Preferred IV route. Large accessible vein is femoral vein. Alternate route intraosseous route. Proximal tibia more than distal femur. Below tibial tuberosity. Automated external defibrillator displays rhythm to decide management. Causes asynchronous depolarization of myocardium. Shock. Shockable rhythm, wide QRS complex. Second non-shockable rhythm. What are the shockable rhythm? Wide QRS complex, irregular rhythm QRS, ventricular fibrillation VFib, regular rhythm QRS, pulseless ventricular tachycardia. What are the shockable rhythms? VFib and VTach. So ventricular fibrillation, irregular and pulseless ventricular tachycardia is also shockable. Then non-shockable rhythm, asystole, pulseless electrical activity. Reversible causes of cardiac arrest, 6H and 4Ts. 6H and 4Ts. What are the 6H? Hypovolemia, hypothermia, hypoglycemia, hydrogen ion acidosis, hypo or hyperkalemia, and 4T is thromboembolism, pulmonary or coronary. Toxins, tamponade, pericardial, and tension pneumothorax. What are the 6H and 4Ts of cardiac arrest? 6H is hypoglycemia, hypothermia, hypovolemia, hyper or hypokalemia, hydrogen ion acidosis. And what are the 4Ts? Toxins, thromboembolism as either pulmonary or cardiac, tamponade, cardiac tamponade, and tension pneumothorax. Shock, condition of circulatory dysfunction, decreased oxygen delivery to tissue and decreased cellular perfusion, insufficient for metabolic demands. Types of shock. Shocks can be hypovolemic shock, most common, which is due to decrease in volume like hemorrhage and dehydration. It could be cardiogenic shock due to congenital heart disease, myocarditis, cardiomyopathy. Distributive shock, anaphylactic shock, and neurogenic shock. Septic shock, features of all three other types. Stages of shock. Compensated stage, if prolonged, then becomes decompensated stage. Compensated stage, vital organ function is maintained, like brain, heart, kidney, and decompensated stage will set up in multi-organ failure. Mechanism of BP maintenance. Sympathetic activation, increase systemic vascular resistance, increase contractility of heart, diverts blood from non-essential areas such as skin. Adequacy of circulation, assessed by capillary refill time, done by blanching of skin by thumb by pressure and noting refill time after. Normal is less than equal to 2 seconds. In shock, it is more than 3 seconds. Compensated versus decompensated shock. Features: mental status, compensated shock, agitation, decompensated drowsiness. Heart rate increased, decompensated markedly increased. Capillary refill time increased more than 3, decompensated more than 5. Urinary output normal and compensated. Oliguria or anuria and decompensated. Blood pressure normal and compensated, decreased and decompensated. Respiratory rate increased in both compensated and decompensated shock. Hypovolemic shock. Suspect when compatible history of fluid loss. decrease oral intake. Findings: dehydration like dry mouth, absent tears, sunken eyes, renal perfusion, oliguria, increased serum creatinine, increased blood urea. Central venous pressure, hypovolemic shock, loss of plasma or blood volume, decreased venous blood, decreased preload. Cardiogenic shock, impaired cardiac contractility, venous pooling of blood. Presentations of primary pathology of heart, murmurs and frictional pericarditis. Findings: increased central venous pressure, increased jugular venous pressure, S3 gallop, and congestive hepatomegaly. Distributive shock, also known as warm shock. Findings: warm extremities, bounding pulses, capillary refill time, flash less than 1 second, called as warm shock. Decreased cardiac output, decreased afterload, decreased systemic vascular resistance, vasodilatation. Septic shock, cold type and warm time. Cold extremities, warm extremities. Capillary refill time is increased in cold. Warm, it is flash, that is less than 1 second. Pulses feeble, decreased pulses in cold. Bounding pulses in warm. Management algorithm for shock. Quick recognition of shock. Stabilize ABC by high flow O2 inhalation. Obtain IV access inaccessible for 60-second intraosseous access. Check and treat for hypoglycemia and sepsis. Fluid therapy by initial fluid bolus 10 to 20 ml per kg over 15 to 20 minutes. No response 20 ml per kg over 15 to 20 minutes. Repeated up to 60 ml per kg in first hour. Fluid therapy, no response for 60 seconds. Fluid refractory shock. Cold shock requires vasodilatation. Warm shock requires vasoconstriction. Cold shock, epinephrine or dopamine 5 to 9 microgram per kg per minute dosage, or warm shock, norepinephrine or dopamine more than 10 microgram per kg per minute dosage. Start dose 0.05 microgram per kg per minute, titrate up to 3 microgram per kg per minute. No response, catecholamine resistant shock. Catecholamine resistant shock management: corticosteroids is if suspicion of adrenal insufficiency, cardiac monitoring, transfusion to keep hemoglobin more than 10 gram per deciliter, cold shock plus normal blood pressure, vasodilators, nitroprusside, milrinone, nitroglycerin, levocimendane. Cold shock plus decreased blood pressure, titrate epinephrine highest dose plus norepinephrine to normalize diastolic BP. No response, milnirone. Leocimendane. Warm shock plus decreased BP. Titrate volume status to normal with fluids. Add vasopressin to cut vasoconstriction if cardiac output is decreased. Milrinone and levocimendane. No response, look for reversible causes like pericardial effusion, pneumothorax, extracorporeal membrane oxygenation, ECMO, oxygenation of blood through a machine outside the body. Site of intraosseous access, proximal tibia, distal femur. Rule of 60. Rule of 60. 10 access to be obtained if intraosseous access to be obtained if IV not available in 60 seconds. Fluid boluses up to 60 ml per kg in first 60 seconds. Start vasoactive drugs 60 minutes after starting fluid therapy. Fluid therapy, crystalloids, decreased price and easy availability, more than colloids. Long-term risk of usage in children, unknown. Normal saline, 0.9%, ringal lactate. Isotonic solutions only. Management of sepsis. Third generation cephalosporin and vancomycin, vasoactive drugs, vasopressor, after vascular resistance, epinephrine, norepinephrine, vasopressin. Ionotropes, increase cardiac contractibility, epinephrine, dobutamine, milnirone. Phosphodiesterase 3 inhibitor, levocimendane, myocardial calcium sensitizer. Vasodilators, dilate blood vessels, nitroglycerin, nitroglycides. Therapeutic endpoints, normalization of vitals, normal heart rate and blood pressure, urine output more than 1 ml per kg per hour, CRT less than 2 seconds, and mentation is normal.